All right, here we go. So as a last lecture, Virtual Classroom decided not to record this. So therefore, I'm posting this on my page. So I'll try not to. This is a G-rated presentation. I will try not to express my thoughts of Virtual Classroom. So anyway, here you are on my Dr. Doug's or Professor Doug's lecture page. Anyway, it's our last lecture, right? It's week 10. It's Thursday, our last CVPP lecture. So I hope you enjoyed the course. And I got probably another 2,000 slides I could go through. If you want me to, I'll keep right on going. But I think you've probably had enough, right? All right, here we go. Let's get to it. So now remember, I left a note for you guys on Brightspace saying please watch the kind of anatomy, physiology, histology, embryology review of the respiratory system, right? Or you're going to maybe be a little lost. So I would go back and look at that. It's on Professor Doug's lecture page as well. All right, so here we go. Assuming you've watched that and you're all up to speed, let's start talking about obstructive lung disease. And AKA from Robbins, it might be called airway disease or obstructive lung disease. What's obstructive mean, you think? Obstruction of what? Obstruction of the pipes. So this is a obstruction of the flow of air through somewhere, through part of the tracheobronchial tree, if not all of the tracheobronchial tree. And that something is going to block. The question is, what is that something? And those people affected, if your tracheobronchial tree is blocked, you're going to have trouble breathing, right? And it could get so bad that you become asphyxiated. You can't breathe, can't get air in. And that's kind of the end phase of this thing. One before, we're not going to have time to talk about a lot of this, but restrictive pulmonary disease versus obstructive lung disease. Don't get these two confused. Obstructive means that the pipes, the tubes are blocked somehow. And restrictive means that the lung is actually being compressed by something. And relevant to chiropractors, this is a good something here. It's a kyphoscoliosis, severe kyphosis here, can crunch down on the lungs and they can't expand because the chest cavity is so distorted. Severe obesity, neuromuscular diseases can also do this, polio. But scoliosis is notorious for starting to knock out pulmonary function, and you could get a restrictive pulmonary disease. There's other ways as well. Interstitial fibrosis, pneumoconiosis are examples of restrictive disease where the parenchyma of the lung gets destroyed and the lung can't stretch and it can't contract. So that's another way. And that's all I'll say about restrictive. The rest of our time is going to be talking basically about COPD. But let's finish this little section. We are going to talk a little bit about cystic fibrosis too. Obstructive lung disease, super common. It's the second most common cause of permanent disability, according to the Social Security Administration in the United States. The first is heart disease. The world prevalence of this disease is thought to be 16%. So this isn't Marfan syndrome, 0.01%. 16% of people, you're going to run into this for sure because of all the baby boomers you treat. And the mortality rate has been increasing despite our advances in treatment of this disease, and we don't understand what that is about. Categorizing obstructive lung disease is difficult because the diseases tend to overlap. And so sometimes you're not 100% sure if the patient has emphysema or do they have chronic bronchitis? And reality is they probably have a mix of both of these diseases. So here are the subcategories of obstructive lung disease. We have chronic obstructive pulmonary disease, or COPD, which we've talked a lot about here and there. And remember the subcategories of COPD are emphysema and chronic bronchitis, at least for chiropractors. For medical docs or young medical students and physical therapy students, a lot of the big books include chronic asthma as a member of emphysema and chronic bronchitis. So make sure you check with your board book, your board reference book, to see. If it's Robbins, then emphysema and chronic bronchitis. If it's some of the other big books, then you would add chronic asthma to that, because they all have similar findings. It can be hard to tell one from the other, and the patients have a little bit of all of those. Some other subcategories: chronic asthma, if it's not included under COPD, bronchiectasis, and then some congenital problems: chronic tracheal obstruction, chronic bronchial obstruction could fall into that category. What's one thing that all obstructive lung diseases have in common? Well, the airway's obstructed, just like the word says. And how can the airway be obstructed? There's three different types of obstruction. You can have a problem inside the lumen itself, almost like small bowel blockage, right? We talked about small bowel obstruction, the same deal. You can have a problem inside the lumen. You can have a problem inside the wall of the airway, or you can have a problem outside the wall of an airway. So let's look at these a little more carefully. So here's an example. Chronic bronchitis is a perfect example of stuff inside the lumen. So here's a bronchiole. Could be a bronchiole. It could be a bronchus as well. But here we have really thick and sticky mucus that is inside this tube. And obviously the air can only get through this part. So the patient would have trouble breathing, right? Cystic fibrosis can do that as well. Now, how about an example of something inside the wall itself? How about a enlarged mucus gland? And we see that in asthma. Asthmatics have very large mucus glands because they keep having attacks of asthma, and the glands keep working out. And if you work out, you're going to become hypertrophied, and they can start to narrow the lumen down because they're so big. And then a problem with outside. So there's a couple ways here. This is an example of emphysema. Emphysema destroys the parenchyma, and it destroys some of the elastic fibers that are attached to the bronchi, or the bronchus in this case. And if they break, remember we said there is no cartilage in bronchioles, for example. And so without radial traction, they will just squeeze in on each other. You could also have a tumor growing right here, pushing in on the lumen as well. So those are examples of problems from the outside. More specifically, the interluminal instructions, excessive secretions. Chronic bronchitis is the first one that comes to mind, but asthma, if you're having asthma attacks frequently, you have an oversecretion of mucus. You can get mucus plugs from asthma attacks. Cystic fibrosis, although it's rare, it's notorious. I mean, that's really what does people in with cystic fibrosis, is the mucus is described as tenaciously thick and sticky. In fact, let's fall down the cystic fibrosis hole. Now, we talked about this. If you've taken GIGU as well, we've talked about the pathophysiology of this disease, so it's going to be about the same thing. But here it is. Cystic fibrosis, aka mucoviscidosis, means thick mucus. That was the original description of it long ago, but it's still a valid AKA nowadays. It is a deadly, life-threatening disease. These patients they lived to 30, and just recently the new books and research has got them up to 40, so they're doing better. But they don't live that long, right? Almost half of their life is cut out usually because of a chronic pneumonia. Pneumonia gets them. It is the most lethal genetic disorder that white people get, period. 95% of the time, if someone gets affected, they're going to be a Caucasian. Much rarer in African Americans and Asians. Epidemiology is about 0.04% of the population, so still much more common than Marfan syndrome. Prevalence in the United States is about like Marfan syndrome, about 0.01%. So just a tiny bit more rare than Marfan syndrome. As we've already talked about in GIGU, it affects many different organ systems. We talked about its effect on the pancreas and the effect on intestines, sweat glands, reproductive organs, and now we're going to talk about the lungs. In fact, almost all of the deaths that occur because of cystic fibrosis is secondary to a pneumonia, its effect on the lungs. But it still can be quite disabling if it gets into the pancreas. Exocrine pancreatic insufficiency, right where you don't secrete the pancreatic juices, you're in all sorts of trouble because of that. So it can be very disabling if it's in the intestines or pancreas as well. It's typically caught by the age of 5. We already know the mom will be kissing the baby all the time, and all of a sudden she notices the baby is incredibly salty, and that's a bad sign. With regard to genetics, it's a Mendelian autosomal recessive disorder, which means both mom and dad had to give the baby a mutated gene. So it's autosomal recessive. What is the cause of this? Well, it's a mutated gene. Well, specifically, it's the cystic fibrosis transmembrane conductance regulator gene, or we'll just call it the CFTR gene from now on. It's a mutation that lives on chromosome 7, specifically location 7q31. And this is the gene that writes a messenger RNA that describes instructions for a ribosome to build one of these things. And that's a CFTR channel. It's a chloride anion channel that is found in the cell membrane of epithelial cells that line the, see it's ciliated, it's a ciliated columnar looking cell there, so that line the tracheobronchial tree. And remember, there's actually, if you want to get technical, there's actually 5 classes of CFTR mutations. Class 1, 2, and 3 are the severely just really bad genes where not many CFTR channels are made at all. There's 2,000 mutation combinations that have been described. The classic one that might show up on boards is a class 2 mutation, which is bad, but it's not as bad as the class 1, 2, or 3. This is the famous, the delta 508 mutation. There's the sign for a delta F508 mutation. F stands for phenylalanine because the messenger RNA does not contain instructions to place a phenylalanine molecule in the protein of the CFTR channel. And therefore, because it's missing one phenylalanine molecule, it ends up misfolding. Specifically, the glycosylation doesn't occur correctly, which causes the misfolding. But if it doesn't fold correctly, it has to go through the rough endoplasmic reticulum for processing, and rough endoplasmic reticulum spots it and tags it for destruction. It gets destroyed, which is a shame because the thing still works. If we could turn off that tagging process in the rough endoplasmic reticulum, that might be a treatment for cystic fibrosis. We already said the CFTR channels are proteins. They're found in the epithelial apical membrane. They're ubiquitous throughout the body, but they particularly love the epithelial lining of glands, crypts of Lieberkühn, for example, and ducts, especially in the pancreas. But all the ducts, all the bronchioles and the bronchus, or the bronchi, the tracheobronchial tree is full of these things. So what do they do? Well, we know what their job is. They're a chloride anion pump, so they pump chloride out. With regard to the lungs, they pump chloride basically into the lumen of mucose glands and into the lumen of just the tracheobronchial tree, like the bronchioles. And where chloride goes, sodium follows. Between the cells, it can get through there, or it can use some transporters, sodium potassium ATase pumps, ENaC channels. There's all sorts of ways. Sodium will follow chloride, and who follows sodium? Water. So basically, you're getting water into the lumen of a mucus gland and getting water into the lumen, and we're talking a little water, right, into the mucociliary escalator system. And that water is super important because it thins out mucus, so it makes the mucus not super sticky. And I took the slide about bicarbonate out. Mutations in bicarbonate channels are also related to cystic fibrosis. It turns out bicarbonate is necessary to make the mucociliary escalator, specifically the sol layer, more amenable, the gelator, the mucus in the gelator. It's necessary to make the gel more amenable to the reabsorption of water. So you need bicarbonate and water to make the mucus get more relaxed and more normal. If the CFTR channel is broken, you can't dilute the mucus, and you get a incredibly sticky, it's described as tenaciously thick mucus. And that can clog up the ducts and clog up the tracheobronchial tree, and it knocks out the mucociliary escalator. So how are you going to get all the dust and the fire particles right now? It's not quite as blacked out today, but last 2 days it's been really dark here in California because of all the fire, and the air quality is probably the worst ever recorded. How's that going to get out of your lungs if you don't have a mucociliary escalator? And that's what cystic fibrosis patients have to deal with, including the bugs. The bugs won't get out. They'll burrow into the tracheobronchial tree wall, and they'll cause an infection, and that's pneumonia. And that's the trouble with cystic fibrosis patients. They get pneumonia after pneumonia after pneumonia because of this super sticky mucus. Here's just a little cartoon. There's a CFTR channel, and there it's spitting chloride out. Here's a glob of mucus that needs to be diluted, and so chloride goes out. Sodium will follow the chloride, and water will follow the sodium. And bicarbonate would be in here as well to kind of loosen this up for the water. And so everybody would be happy if that would happen. But if this is mutated and doesn't work, well, if no chloride gets kicked out into this bronchial lumen, then no sodium goes out there, and then no water goes out there, and then you got this incredibly thick mucus. And the bugs, there's a bug. There's a bug. It's stuck, but it can't get out. So the bug is going to breed another bug. And these bugs are going to go down into the wall of the bronchiole in this case and spark an inflammatory response. The sequelae of thick mucus, everything we said, it destroys the mucociliary escalator, and patients get pneumonia. You get an infection. And that's what ends up, as I said before, it ends up killing people is pneumonia. It's not actually the cystic fibrosis that kills you. It's the sequelae of it, like pneumonia or pancreatitis or something like that. And what else? Yep. And plus the mucus, just that thick mucus, maybe there's not a lot of bugs on it, but it's so thick it causes an airway obstruction. So you can't breathe well. All right, there's a better drawing. Remember the gel layer, the mucus is 2 layers thick. There's a loose kind of serous fluid mucus type material here. It's thick enough to stick to this gel, super sticky mucus like flypaper. But it's not so thick that the cilia can't push this whole thing towards the larynx. But people with cystic fibrosis, you can say goodbye to the serous layer. It's just everything is super, super sticky, and it paralyzes these cilia. They can't work because they're stuck in all the mucus. Are we out of the rabbit hole? Yep, we're out of the rabbit hole. So that's into cystic fibrosis. We talked about intraluminal obstructions. That's where we left off. Another type of stuff that can fill up the lumen is edema. You can get pulmonary edema, and we've talked about that before. If you have a beaver dam, let's say your heart is failing or your left heart is failing, and you have a backup of blood waiting to get out of the lungs to get processed by the heart and get ejected, and that backup of blood is going to raise the pressure in the microcirculation of the lungs. And if the pressure gets high enough, you'll start dumping too much blood fluid into the interstitium between the capillary and the alveoli. And if the pressure gets still higher, you're going to actually push that blood fluid into the alveoli. So now you got basically interstitial fluid dumping into the alveoli, and you're starting to drown. You're not supposed to have any fluid in there. And then if it gets even worse, you can get red blood cells dumped into there as well. And you get that pink frothy sputum. Remember, there's the alveoli. If you watch my video, you're all up to date on this stuff. But these alveoli, there's an alveolar sac right here, which is connected to an alveolar duct, which you can't see very good. And there's a respiratory bronchiole. Those are the three respiratory units, all where gas exchange occurs. And so, yeah, that's the deal. You can get, if you have a beaver dam here, the pressure builds up and you start dumping blood fluid into the interstitium, and even red blood cells can get into the alveolus, and you start coughing that stuff up and got yourself hemoptysis. What about another type of intraluminal obstruction? How about a physical block? Or you could grow a tumor. You could grow a cancerous tumor inside the bronchiole as well. Here's the little kid who swallowed a piece of metal. We said in my video, it always goes down the right main bronchus because it's more vertical. And there it is. So we got a massive blockage here. Doesn't look like much atelectasis has happened here. I'll show you a picture of that. Not yet anyway. Trachea hasn't deviated yet. But nevertheless, that's causing trouble with breathing, right? How about an intrawall obstruction? So we looked at inside the tube. How about inside the wall? Well, an unwanted muscling up of smooth muscle. So patients who have chronic asthma, chronic asthma involves a spasm of the muscles, mainly of the bronchioles. And people who have asthma all the time, those muscles are exercising so much they get really hypertrophied. And the bigger they get, the lumen gets smaller and smaller and smaller. So that's an example of an intrawall problem. The muscle is inside the wall, and it narrows those holes. We already talked about asthmatics and people with chronic bronchitis. They're overusing the mucus glands, so they get buff, and they work out, and they get big, and they can also narrow the lumen as well. And the chronic inflammation causes edema within those walls, right, if there's an inflammation going on. And so that can also help with the thickening of the wall and narrowing of the lumen. Right? So typically chronic asthma and bronchitis patients, or viral bacterial infection, although you can get rid of that one at least. How about a peribronchial obstruction? So that means the problem is outside the lumen. So we looked at loss of radial traction is a big problem. We already kind of talked about that. But how about physical things pushing into the bronchiole, like a tumor or a cyst or a lymph node, or maybe you got a bleed going on, or maybe you got a bug ball, tuberculosis or something going on. Those can all pinch the pipe shut. Matter of fact, here's a patient. Well, let me take some water while you look at that. Tell me, is that a normal? Of course, it's not normal. It's a patient with pulmonary chordomas who came in having trouble breathing. You took a chest film, and lo and behold, there you have those lesions. And the problem was the lesions were smashing so many of the pipes. A lot of the lung wasn't working because the pipes were pinched off. Patient has dyspnea because of that. Loss of radial traction we talked about, small airways. The bronchioles, for example, they have no more cartilage. We talked about how big airways have cartilage rings that hold them open from the incredible negative pressure that occurs when you take a breath in. But the bronchioles don't have any, so they rely on kind of springs attached to the outside of the walls that hold those pipes open. If you have diseases that destroy the parenchyma of the lung and destroy that cartilage, well, there goes your ability to hold those pipes open. So that's called radial traction. So you lose radial traction in diseases like emphysema. And that lets your pipes snap shut naturally, and you can't breathe because your pipes are clogged. Right? We looked at that before. Loss of radial traction, everything I just said, destroys the lung parenchyma. Without the radial traction, the small airways, like especially bronchioles, collapse, and you can't breathe. There's an example of a bronchiole or bronchus. And there's one in someone with COPD, namely emphysema, where these elastic fibers have been destroyed by the disease, by an inflammation. And without those tethers, the pipe just snaps shut. All right, now let's look specifically at COPD. Kind of been talking about it, but it's, again, one of the subcategories of obstructive lung diseases. It is an umbrella term, as we've said already, including emphysema and chronic bronchitis. Those two are almost always mixed together. Some authors include chronic asthma, but chiropractors don't because Robbins doesn't. And in reality, most patients with COPD, they have a mixture of emphysema and chronic bronchitis. It's very rare to see one without the other. This is an irreversible condition, and it may be the end of the patient. It often becomes fatal at the very end. You can sure prolong it, though, with treatments, but you can't fix it. What are the classic signs and symptoms of someone with COPD? A progressively shortness of breath, a dyspnea on exertion. Last year I could walk a mile. This year 3 years ago I could walk a mile. 2 years ago, 3/4 of a mile. 1 year ago, a half a mile. This year I can only walk 4 blocks. I just am exhausted. I can't breathe. I'm out of breath. That's a progressive shortness of breath. The chronic cough, especially if it's chronic bronchitis predominant, these guys cough like crazy. And the cough is each winter, especially in the winter. Cough started 3 years ago in the winter. And then 2 years ago, it started to last into the summer. And this year, it's all year round. I'm coughing in the morning. These patients are usually smokers as well. Exercise intolerance, as we said, they can't walk upstairs. And the symptoms get worse with the passage of time. What about image findings? Are there any image findings associated with COPD? Yeah, collapsed lung, atelectasis. Remember, we've talked about that before. How did we talk about atelectasis before? What was the subject? Josh, what's the answer to that? Josh probably knows. Josh is correct. I've read his mind. So we talked about the fluid, what did I got to think, when did we talk about a collapsed lung? Oh, we talked about it in lab, I think. That's where we talked about it. Where a hydrothorax, if you get enough fluid in the lung, it can push into the lung tissue and pinch it. I think we talked about a bleb. Asthmatics have bleb, so you could get a pneumothorax. Can also collapse the lung. We've talked about it in several places. So, kind of the opposite of atelectasis might be an overinflation. And people with COPD have sometimes overinflated lungs that are so big that they give them a barrel chest. Let's talk about it. So what we haven't talked about is another type of collapse of the lung. This one is not from something pushing, like a tumor pushing into the lung, or if this was filled with fluid here, we could get an atelectasis from a hydrothorax or from a pneumothorax, pushing the lung in this way. But what if we get a big mucus plug right here in one of these segmental bronchi? Well, all the air downstream is going to be sucked out of the downstream tubes, and it's not going to be replaced. And as the air gets sucked out and can't be replaced, the lung is going to shrink, and that's called resorptive atelectasis or resorption atelectasis or obstructive atelectasis, all AKAs for that. So that's another type of atelectasis. Let's talk that one over a little bit. So reabsorption atelectasis, I've heard it resorptive atelectasis, obstructive atelectasis. When something completely blocks one of the small airways and the air gets sucked out, just like I said, the tubes in the lung tissue will collapse because it can't be replenished by air. And if a big enough pipe gets clogged, like a segmental bronchi, there goes your lung. A huge piece of your lung will disappear. So here's an asthmatic. After an asthma attack, they left the hospital and they thought all was well, yet this mucus plug had knocked out a segmental bronchus here, and slowly but surely this whole lung collapsed and the patient had a lot of trouble breathing. There's an example of a compression atelectasis from a pleural fluid that's built up in there. What do you think of this? 55-year-old chest pain and dyspnea, long history of COPD. Yeah, it's atelectasis, right? You can see this is the left lobe. You can remember the left lung has a superior and inferior or upper or lower lobes. No problem here. What in the world's going on here? What's that? That's the oblique fissure of the lung. Okay, and we know the oblique fissure of the lung walls off the superior lobe of the right lobe. So that lobe is collapsed and has no air in it. Remember, air lets photons fly right through it. No photons here because all the tissue is collapsed. Therefore, that's an example of an atelectasis. Epidemiology, not good. Grim Reaper has joined us. This is the third leading cause of death in the United States. What? That's like a surprising, that was, when I put these slides together, that was surprising for me. Third leading cause of death, only behind cancer and heart disease. Population prevalence of COPD by itself in the United States in 2013 was 6.4. I'm sure it's higher than that now. It's a Caucasian disease. About 80% of COPD deaths between a 10-year span were Caucasians. About 43% of heavy smokers will develop COPD. Not all heavy smokers get COPD, but it's certainly a risk factor for it. Now, I hate to do these, but I keep hearing these are on boards. Hear rumors anyway that these are on boards. So we got to do these, the old pink puffer and blue bloater. But the two classic clinical presentations was presented type A COPD and there's a type B COPD. We don't really, like medical students of physical therapy, I don't think you use these anymore. Again, check your board books, but Robbins still talks about them. And that's our board book. So COPD type A and B. Classically, type A was you're not very symptomatic, and then you would progress into type B, which is ridiculous. People can die from type A COPD, and because that's emphysema is type A. People die from that all the time. But this classification has been around for a long time. Weinberg goes off on this, that's one of the medical school texts. Many medical schools board books use that. But again, check with your boards to make sure who's using it. But reality, people have features of both type A and type B, the original type A and B diseases. And as I said, people with type A die all the time because that's usually emphysema. Therefore, type A and B subtypes are no longer included in the definition of COPD in modern texts. That was Weinberg in 2013, yet it's still in some of our board books, so I don't know what to say about that. Definitely still on chiropractic boards from my understanding. So let's go through it. I think you know this already. So type A is the pink puffer. The male in his 50s is when it usually starts, just like type B, male in his 50s. Type A, they get shortness of breath over the last 3 or 4 years. I used to be able to walk 2 miles and then 1 mile. Now I walk a couple of blocks and I'm panting like crazy, getting progressively worse. They're usually smokers. They're pink in color. They're not blue bloaters. They're pink puffers. So the oxygenation, the ability to exchange gases hasn't been that affected. And remember, this is not really true, but according to this originally classification system, that's what you go with. These patients usually aren't coughers. They may cough a little bit. They may have a little bit of phlegm that comes up. Sputum is probably phlegm would be a better word there. If it does, it's clear. It's not green. It doesn't stink. So coughing's usually not that big a problem. They're not cyanotic either. They're pink puffers. So therefore, their oxygen levels, their PO2 levels are good. They don't have acidosis. If you auscultate them, they'll sound normal. They won't have any adventitious sounds going on. They're typically skinny. That's called an asthenic body type. And they usually have predominant chronic emphysema. Type A goes with emphysema. Type B goes with bronchitis. Now, advanced type A, and this is I'm trying to show you that it can get bad. That what I just talked was classic. Now we're going to kind of try to make this more usable. So advanced type A, they can have their lungs destroyed. This is an emphysema, and that destroys the parenchyma of the lungs, and it destroys alveolar walls and lets alveoli coalesce. So here we have an alveolar sac. You remember, because I know you just reviewed my video, right? So you know what an alveolar sac is. There's many alveoli in an alveolar sac, and that's fed by an tubule. Alveolar tubule? My brain just blanked. Alveolar tubule, because there's a respiratory bronchiole and there's a alveolar tubule. And remember, alveolar tubules can have a couple alveoli coming off them as well. But anyway, COPD destroys these walls, and it destroys this wall. It destroys all these. So instead of 5 little units here, you have 1 unit, and it stretches way out because they're not designed to take that much, the pressure, this outer membrane that's left. So you get these huge kind of dead areas, and it doesn't work either. It collects air, and it doesn't work. It's too big to pass air through this little tubule. So you get this huge buildup of these dead air spaces, and that makes your lungs get really big. And it usually makes them get big in the A to P diameter, so you get a barrel chest. Remember, normally the lateral diameter is bigger than the A to P diameter. This is anterior here, right? And so they get these barrel chests where they have like almost a 1-to-1 ratio. Why? Because they have all this dead space. These coalesced alveoli have coalesced together. So toward the end, you might see some accessory muscle breathing. So they're using their intercostal muscles because they can't breathe. This doesn't work. They're only getting oxygen from their upper part of their lungs. So they have to breathe really hard, and they're engaged their accessory muscles. And their SCMs will be contracting, and they might be pursed, doing like a monkey kiss and breathing through lips like that, which helps with decrease the negative pressure within the airway. What do you think of that? I'll get some water here. Well, it says it's normal, so that's a normal PA chest film. What's this? Is that a tumor? Hilus. Okay. What do you think of that? Thin, barrel-chested 60-year-old male comes in with complaints of severe exertional dyspnea, low levels of energy. What do you think? That's no good, right? Look at how skinny. The heart is being smashed because the lungs are overexpanded. Look at how lucent they are down here. That's all dead, non-functioning tissue. In fact, one of the treatments for these people is they surgically cut all this stuff out, which relieves the pressure on the heart, and the pressure on the barrel chest will be gone after a procedure like that, because this tissue is dead and not doing any good. But yeah, so low hemidiaphragms, narrow mediastinum, increased translucency in the lower lobes, classic type A. Really, it's emphysema, that's what it is. But classic type A, if the question has a COPD type A, think emphysema, and that's the answer there. Patient had severe emphysema. Okay, now here's our blue bloater, who's supposed to be more sick than the type A, which is ridiculous, but according to this traditional system, he's blue because he's cyanotic. He's got oxygen. He needs oxygen. So these are also males in their 50s. They're heavy smokers. They have a horrible cough in the morning. Their mucociliary escalator is completely destroyed. It's morphed into squamous tissue. Their expectoration, they're spitting up phlegm that stinks. It's green. It's filled with bacteria. It's nasty. Why do they have the cough? Because their mucus escalator is destroyed. The smoking has caused an epithelial metaplasia. And from all that irritating cigarette smoke, that pseudostratified, those cells can't stand the smoke. And so the body said, well, we'll fix that. We'll get rid of them. We'll morph that tissue into something that can stand the smoke. So it morphs into a non-ciliated stratified squamous. That can handle the smoke. But there goes your mucociliary escalator, and you can't sweep the gunk out of your lungs. So you have to cough and hack it up every morning. And these patients, just like people with cystic fibrosis, are prone to infection and pneumonia and all sorts of problems. The expectoration has been increasing in severity. Yep, this is the example I gave in the winter months. Started out 3 years ago, just in the winter. 2 years ago, we kicked into the summer before I got rid of that darn cough. This year, I've had the cough since the winter. I can't get rid of the cough. Something's wrong. Yeah, they have COPD. They have chronic bronchitis, which is COPD. It's a classic presentation of that. And we said the phlegm is stinky, it's foul, it's green, it smells. That's chronic bronchitis. Exertional dyspnea is becoming more frequent with these patients as well. They're typically heavy smokers, typically more than 20 pack years of smoking. What's a pack year? You take the packs of the number of cigarette packs per day, you estimate that, and you multiply that by the number of years they're smoking, and it'll give you their pack years of smoking. That's a useful number for pulmonologists to use. And yeah, they have chronic infection all the time and pneumonias, and it damages the microcirculation. These battles where bugs can't get out and bugs take over, and your immune system kills off the bugs, but it scars up the microcirculation, and now the right heart has trouble pumping blood through the lungs. Right? We've talked about that. And what happens to the right heart? It gets destroyed. Right? It gets really big and muscular and thinks it's tough at first, but then it can't keep that pace up, and it gets destroyed. And that is a perfect example of cor pulmonale, which is right-sided heart failure from a primary lung condition. What's the number one cause of cor pulmonale? Josh? He's correct. It's left heart failure. But if someone has left heart failure, do they have cor pulmonale? No, you just have to say they have right heart failure. Cor pulmonale means that the primary condition has to be the lungs, like COPD. Said that like a million times. You better not miss that on boards. Take a chest radiograph. They're not going to have a barrel chest, but they're going to have heart changes. They're going to have right ventricular hypertrophy. They may have some congestion in the lung fields. You take an EKG, the axis might swing way to the right. Right? Here's a chest film. Right? Look at that. The heart has rotated. The heart looks big. The left heart failure too in this one. But the heart is rotated over, so the right ventricles are now over to the left, bowing that out. The right atrium is way too big. You decide to take an EKG, and the 67-year-old wife says he's been a heavy smoker for many years, hacking cough. What do you think? Remember this one? Look at that P wave. That's way too big. It's taking tons of voltage to push through the atria. So that means the atria are enlarged. And we can also go, what's the axis? What the ventricular mean electrical axis? Which way is it headed? Well, remember that? Well, grab the most biphasic wave. I guess it would be limb lead 1. Limb lead 1 would be over here. That's the angle of orientation, looks right from 0 degrees. So that a camera would be here. Draw perpendicular. There's a perpendicular. Now we need to know. So the current is going semi-perpendicular to limb lead 1. Now we need to know, is it going toward the south or toward the north? Do we know a limb lead down here? Yeah, that's the peeper, right? That's AVF. So if the QRS complex is more positive, it means it's heading right at it. Is it more positive? It absolutely is more positive. AVL is probably going to be more negative, right? And AVL is definitely negative. So the current is running this way. Now the question is it running perfectly perpendicular? No. The current's going this way. And the rule is if the up part is smaller than the down part, that means the current is running more away than perpendicular. So the current would be running more like this. And we know that this is the normal axis, right? So it's shifted to the right. So that's a right axis. Oh, I forgot I drew this, so I could have done that, right? Draw the perpendicular here. Figure out which way it is going, and then fine-tune it. Yep, the positive part is small, so it must be running away, so it's running like that. Got it? Better know that. I guarantee you those are going to be on my test. What about COPD? What else? The blue bloater, because they become cyanotic as you get toward the end phases. So they get... why do they become cyanotic? And these blue bloaters. Well, they can't... they don't have the alveoli, and the pipes are all messed up. They can't oxygenate them. They can't exchange gas. So therefore, they get respiratory acidosis. They have hypercapnia, that's increased levels of CO2. Hypoxemia, that's decreased levels of oxygen, and respiratory acidosis. Remember your physiology. How do you, when you blow off CO2, how does that get rid of the acid? You should know that for your biochemistry. Remember, you need carbonic acid to make CO2. And let's just look at this. I like this picture. So if you're normal and you're getting rid of CO2, to make CO2, a lot of it travels as HCO3. And that combines with hydrogen ion. There's a hydrogen ion. That's carbonic, or that's bicarbonate, right? So bicarbonate soaks up the hydrogen ion, and it's converted, can do it naturally or with carbonic anhydrase quickly, or can do it slowly. But nevertheless, hydrogen ion is sucked up by carbonate to form carbonic acid. Carbonic acid dissociates to CO2, which diffuses out because of a pressure gradient. And the hydrogen ion is turned into water. So it neutralizes that hydrogen ion. And inside the red blood cell, it happens even faster. Because as oxygen's coming in, you get an oxyhemoglobin, and that hemoglobin sheds a hydrogen ion, which has to be grabbed by carbonic or by bicarbonate. Bicarbonate hydrogen ion combine with the help of a enzyme, carbonic anhydrase, to do that same thing. It makes CO2 and H2O. So again, we're getting rid of the acid by converting it into water. So if this is all clogged up with scar tissue and mucus, this process can't happen. The CO2 in particular can't come out. So if you can't make CO2, there's nothing to soak up the hydrogen ion. So hydrogen ion starts to build up in your blood, and that's respiratory acidosis, right? In a nutshell. Go review your physiology. I'm sure whoever taught you that. Who did teach you that? Was that Dr. Doe? All right. Asthma. Let's look at asthma. So asthma is characterized by sporadic attacks of dyspnea. These people go into attacks and they can't breathe, and they think they're going to die, and they panic. And different magnitudes of it too. But it occurs when you get bronchial spasm of the smooth muscle, mainly in the bronchioles themselves. That has, pound for pound, has more smooth muscle than any other region. And if your muscles spasm up, you're going to have trouble moving air through those pipes, and you can't access those alveoli if the bronchioles are all clogged up and you can't breathe. The muscular terminal bronchioles are the most affected, fun fact. And they can, you can't breathe. They're dangerous. You could die from this. You can asphyxiate if you have a severe asthma attack. Really scary. Nice little picture here of a normal airway. Here's someone having an asthma attack, and the smooth muscle is way too big, and the glands are over-secreting mucus to make things even worse. And you can't breathe. You got to breathe through that little tiny hole compared to that big hole, so you can't breathe. It's a terrible. Son-in-law has this condition. Having trouble right now because of all the smoke out there. I told him, wear your N95. And what does he do? Comes over today with one of those little gangster, how would you say that? That little scarf over his nose. I'm like, what in the world are you doing? What did I just tell you? Why is your asthma bothering you? This thing is absolutely worthless. So gave him an N95, and he put it on, and he'd probably take it off right after he left. But anyway, no time to digress anymore. So asthma, it's the most common chronic childhood disease. Some fun facts here. In developed nations, so it's more common in kids. About 8% of children and roughly 8% of children and adults are plagued by this condition constantly. They have chronic asthma. It's about 25 million Americans have this problem. There is no cure for it. African Americans seem to have a higher death rate from asphyxia from an asthma attack than other races do. We don't know why that is. Its occurrence is about, roughly you could say, what causes it? It's a genetic condition. About 50% is caused by genes being turned on that aren't supposed to be turned on. 50% due to environmental factors like cigarette smoke, pollution, and you're sensitive and susceptible to those things. What's the pathophysiology? We do know if you're going to be an asthmatic, you usually have a hyperactive or hyperresponsive airway, which overreacts. It spasms and secretes mucus, which is good if you get an invasion of bacteria. That mucus can help kind of flush the bacteria and keep it out of the bacterial wall. But maybe a little pollen may trigger it. There's innocent allergens can set off a wicked response. Even cold air and exercise. There's allergen type and non-allergen type. So you can go through these events, and it triggers a bronchial spasm and oversecretion of mucus, and you can't breathe. We already talked about asthmatics have really big submucosal glands, which make the wall of the bronchus, or of the usually bronchioles, bigger than normal, but it shrinks the lumen. So even when they're between asthma attacks, they don't have the pipes that most people have. Their pipes are narrowed. And then when the attack occurs, they have tons of mucus, thick, sticky mucus that comes out. During an attack, they tend to also overproduce immunoglobulin E or IgE, which is a kind of an allergy type immunoglobulin, right? It causes cells to release histamine, which causes vasodilation of microcirculation, and you get way too much blood fluid going into tissue, and tissue can swell, and it can get into the alveoli and whole 9 yards there. So IgE causes a wicked inflammation process in the bronchioles and bronchi. And then in severe cases, that mucus, especially if you don't go to the ER when you should have, you can get mucus plugs, and they can completely block maybe a lobular bronchus. You're going to have a wicked atelectasis if you take out a lobular bronchus, right? You get a reabsorption atelectasis. Pain and frightening. And the anxiety makes things worse. This girl should be absolutely ashamed of herself, because everybody knows cigarette smoke is a teratogen, and it causes all kinds of birth defects. Shame. Should do the Game of Thrones shame on her. Anyway, positive family history for asthma increases your chances for asthma. A positive history for atopy. We talk about this in dermatology, but atopy means you have a combination of atopic dermatitis, so you have a skin rash, you have conjunctivitis in the eyes, rhinitis, you have a runny nose, red eyes, and a skin rash. You're allergic to everything under the sun, peanuts, shrimp. You're just allergic to everything, it seems. That's atopy. You're atopic if you have that. Prenatal exposure to tobacco smoke and severe pollution is a risk factor. And if you're a smoker now, you have an increase. You can have adult asthma. Just because it didn't start when you're a kid doesn't mean it won't start. There's all kinds of genetic predispositions, which we won't go too deep into. It's actually a little deeper than last quarter's lecture. I added these three. Once it gets to the World Health Organization, it's usually pretty solidly ingrained in the literature. So asthmatics have 3 genes turned on that are normally off. That's the DPP10, the GRPAA, GRAPA-A I call it, and the Sphinx 5. So that's a sign you have asthma. If you have a family member who has asthma, greatly increases your chances. If you've had viral infections when you were a kid, that increases the risk, especially if they're lung infections. What about, there's some research on pre-existing inflammation in asthma. So we don't quite understand how this works, but new research shows that airway hyperresponsiveness that is seen in asthmatics, it could be actually caused by something, specifically a pre-existing inflammation of the tracheobronchial tree. So it's not really that the airways are hyperresponsive, they're pre-inflamed and cranky and irritable, and therefore just a little allergen sets it off because they're predisposed. There are 2 types of way to classify asthma. You can classify it as non-allergic asthma or allergic asthma. More medical way to classify it, which would probably be on boards, is non-atopic asthma versus atopic asthma. Let's take a look at non-atopic asthma. Another AK for that one is non-allergic asthma. And these patients have asthma attacks, and we don't know why. There's no trigger. They've been tested. They're not allergic to anything. They just have out-of-the-blue asthma attacks. And that's what that is. Luckily, that's not the most common form. I don't know if that's lucky or not unlucky. That just kind of sucks if you don't understand it. It's hard to treat. But the treatment's the same for both of these anyway. Atopic asthma, there is a known allergen. There's something that stimulates the asthma attack that they have to be careful of. 40% of these patients have atopy. Concomitant means, you know what that means, atopy. Potential allergens that can set off an asthma attack. certain times of year, certain plants and pollen, certain animal fur, like cats are notorious for some people, fur from other animals, dust mites there's new research on these little things. Some of these guys might actually be allergic asthma patients because of dust mites. That needs to be looked at if that hasn't been tested. There are all kinds of types of asthma. There's exercise-induced asthma. There's emotional asthma. There's cold air. These two are really common, exercise-induced and cold air. You go out in super cold air and it triggers an asthma attack. Don't understand it. Exercise-induced, it's really common. Some pro athletes actually have, ironically, exercise-induced asthma, and they have to take a puffer before they play. Tobacco-induced, occupational-induced, drug-induced, air pollution-induced. What are the classic symptoms of asthma? Coughing. If you're having an asthma attack, coughing and wheezing, can't catch your breath, dyspnea, orthopnea. If you're having an asthma attack, you cannot lay prone or supine. Gravity will be working against you. You need to be in a seated position. Actually bent. There's a tripod position where you bend forward and you put your hands on your knees that some of these people do. And it makes it easier to breathe. It takes some of the stress off the respiratory muscles and lets them do their job better. Anxiety from thinking you're going to die turns on your sympathetics, and that's going to cause bronchial constriction, worsens, vicious cycle. Accessory muscle breathing is now visible. Patient is fighting for their lives. Clinically, you can listen to auscultatory findings. I think I cut off one slide about that, but we can get it now. Asthma goes with wheezing. Remember, that's an expiratory sound with a frequency of 400, about 400 hertz. Right? But it's an expiratory. Someone's choking on something. That can also sound like that, but it's an inspiratory sound when you're choking. That's called stridor. Stridor and wheezing are confusing. Stridor is an expiratory sound. When you're breathing out, you make the noise. Stridor, when you're choking, you have something blocking, stuck in your windpipe or your tracheobronchial tree. It's also 400 hertz, but it's an inspiratory sound. The wheezing is an adventitious sound. Rhonchi, the death rattle, is heard in severe cases. Usually it's heard in people who are close to death, but it's a 200 hertz sound, very low rattling. And usually you could clear that if you had enough energy to do so. If the wheezing occurs during I took all these slides out about the methylene colon challenge. That's how you make the diagnosis. If you can get the patient to wheeze, the diagnosis positive likelihood ratio is 6 on that. So it's a pretty strong indication the patient actually has asthma. You can take a chest radiograph on someone having an asthma attack and you won't see anything. If it's chronic asthma, though, then you could see some overinflated lungs. Remember, chronic asthma is really just part of COPD. Things kind of mix together. They may have a pulsus paradoxus as well. We know people with COPD have a pulsus paradoxus, which we've already talked about. But remember, that's their pulse. You take their pulse, the radial pulse, and you feel it pulse, pulse, pulse. And every time they breathe in, it disappears. They have no pulse, and then it comes back. Yet their heart rate is steady. If you listen to their heart with a stethoscope, there's no disappearing. And we've talked about how the scarred up lungs hold blood back. When you inspire, that extra negative pressure holds blood back, so the left ventricle doesn't fill very much, and you get a tiny little ejection fraction, and therefore not much pressure during inspiration. What's the treatment? Bronchoactive drugs like bronchial dilators are the key. They try to reverse the bronchial constriction, and they're major. There's one that's a huge drug. But let's go through the two classes of these a little bit. We'll do a little physiology, I guess. There's a beta-2 adrenergic selective agonist. What's an agonist? Remember, that binds to a receptor and causes it to work. I always think agonist is agony because it makes the receptor and makes the thing connected to the receptor work. Antagonists block, and the receptor doesn't go through agony because it's got an easy job. So beta-2 adrenergic selective agonists, aka just beta-2 agonists. And these drugs bind to beta-2 receptors on smooth muscle cells located in the tracheobronchial tree, namely the bronchioles and the bronchi, those smaller airways. And they cause the smooth muscle to relax, which opens up the luminal diameter. They're inhaled by something like that, or a nebulizer, which is something at the ER that they have, a little misty thing. And there are different types of the medication we don't need to worry about. If things get bad, they might put you on a steroid if you have an inflammation associated with the asthma attack, which sometimes you get an inflammation after the attack. So inhale corticosteroids. They also not only fight the inflammation, they also enhance beta-2 receptors sensitivity. So the beta-2 agonists will work better in combination with a steroid. But steroids have some negative sequelae we need to look at. So here's the king. Albuterol is the king, the key beta-2 agonists. And here it's binding to its beta-2 receptor on this asthmatic person, and it triggers this chain of events with adenylyl cyclase, creating cyclic AMP, which creates a pKa, which goes into the smooth muscle and relaxes the smooth muscle, which causes vasodilation, and the patient can breathe again. There are some short actors. Albuterol is considered a short-acting bronchial dilator. There's levoalbuterol as well. Albuterol is the famous one, though. These are called rescue inhalers that people have to carry around with them to treat acute attacks of asthma. They work within 15-20 minutes. Their effects can last for about 6 hours. Some athletes who are going to have exercise-induced asthma, they need to start puffing on these things about 20 minutes before their event, just in preparation for the inevitable spasm that will occur, bronchial spasm that occurs. When do you add corticosteroids? So the rule on this is little kids and even adults, you don't need corticosteroids unless you're getting asthma attacks more than twice a week. That's kind of the rule, been around forever. Right. Inhaled corticosteroids, they target the lung tissue and they knock out inflammation. We already said they make the beta-2 receptors more amenable to binding. The complications of steroids are not good. Long-term use of, what is the long-term negative sequelae of steroids? Well, one we've talked about in endocrinology is when you come off them, your HPA axis may not wake up, and you may not be able to secrete ACTH, and therefore you may not be able to secrete cortisol because of these. Cataracts, you have an increased risk of cataracts with long-term use. It can make, like any steroid, it can make your skin get thin, and it's associated with osteoporosis, long-term use of these. And it can impair the growth in children, so you want to keep away from the steroids if possible. I guess, do I even have to put this in? I guess I do, because I had some students under the impression that they can treat patients with asthma with chiropractic manipulation. Absolutely ridiculous. Here is a journal article from the Canadian Chiropractic Association 10 years ago, systematic review of the literature, which is very powerful, and they concluded there was no statistical significance. In the best studies, there was 8 great studies that we had, or as good as possible, and there was no difference between asthmatics treated with chiropractic versus not. So chiropractic should certainly not be used as an adjunct and not a replacement, or maybe it can be used. I mean, you can't hurt by trying it, but you certainly should not replace a steroid or albuterol with chiropractic care. You'll be responsible if that patient dies if you try something like that. Why would you do something if the literature doesn't prove that it does it? Great, I don't have time to show this anymore, but a horrifying video, but really eye-opening, of a young lad in the emergency room suffering asthma. And this doctor should do the shame on her terrible bedside manner. Patients, right? She has her back to the patient, saying that he may die. You could see his eyes get wide as she says that. But anyway, it's really good watching this kid go through an asthma attack. He comes out okay. He doesn't die, but you can see the accessory muscle breathing. It's very instructive, so I suggest that you watch that. All right. Well, thanks for the quarter. Sorry we couldn't. Well, we were there a little bit face-to-face, at least in the labs. Mask to mask, I should say. Shield to shield, we were there. But hopefully things will be back to normal. So email me your questions, and we'll see you in the next video.